So, good afternoon. Since morning we are changing our times because our cardiac surgeon was busy with case. In the morning he has taken one case for, case was critical, so he has to operate, so he has operated in the morning. So that's why we have changed time twice. So we are having big hearts. So we'll start. Our panelist, Dr. Nitin Yelikar, he is consultant pediatric cardiologist at Nannadir. He is a big boost for us as we are managing our ICUs. He is there always to help us, and he is trained in Australia also. Another panelist, Dr. Prashant Patil, he is consultant pediatric cardiologist at Care Hospital, Hyderabad. He is visiting many places in Tamil Nadu, Andhra, and in Bhubaneswar also. Another our great cardiac surgeon, Dr. Sarang Gaikwad. He is consultant pediatric surgeon at Asian Heart Institute. Welcome, Dr. Sarang. Dr. Deepak Eklare. He is consultant pediatric cardiologist practicing in Nanded. Yeah. Another pediatric cardiologist, Dr. Mahendra Parihar. He is practicing at Aurangabad at Kamal Nayan Bajaj Hospital. So, why we have taken this panel discussion? Because 10% of the births, 10 out of 1,000 births are because of cardiac diseases. So, we are having a lot of cardiac cases in our OPD practices. So, many respiratory cases are there. In that cases, we are getting many cardiac cases. So, our cardiac team is there who is diagnosing now cardiac cases. So, we'll start our discussion. I'll present my first case scenario. 6 weeks old male child, all right until last week, excessive crying more during night, gets tired while feeding, and his birth weight was 2.8 kg and now weight is 3.1 kg. No history of fever. Other side common problems we have sorted out. He got systolic murmur. So my first question to Dr. Prashant. So how will you proceed in this case? 6 weeks child with systolic murmur. So what are the possible differentials for this? We have ruled out other causes of this murmur like anemia and all the things.
As the symptoms suggest, child has a failure to thrive with feeding intolerance and getting tired while feeding. Along with there is a associated systolic murmur that all goes in favor of a cardiac cause of heart failure. And at the 6 weeks of life, usually the most common cause of a heart failure is a over circulation failure. That means the LV function is normal and the heart is burdened with a increased volume. So mostly these are post-tricuspid shunts like VSDs, PDAs, AP windows, or AV canal defects. Sometimes it may be because of the pump failure as well, where there is a precipitating factor like if some respiratory tract infection and the child was compensated till now, and now because of the triggering factor he goes into failure, such as pump failure can be because of LVOT obstructions like aortic stenosis, critical coaptation, interruption. So mostly this most commonly at this age it is over circulation failure.
So we did echo in this child. It is suggestive of large VSD with dilated LLV with hyperkinetic pulmonary hypertension. So how do you manage this child now? For a pediatrician's point of view, it is very easy for you. For us as a pediatrician who are facing a lot of problem in managing patients, so it is simple for you. So will you just summarize the management of this child?
As child is already in the heart failure, it is better to admit the child in the hospital. The most important, as in any ICU protocol, you have to secure his airway, breathing and circulation, followed by the failure management, which will include the diuretics. The mainstay of treatment is the diuretics, the furosemide and aldactone, along with some afterload reducing agents like enalapril or captopril. Digoxin in this case may not have a major role because the heart failure is not because of the pump failure. Digoxin is only indicated only if you have a tachycardia in it.
Okay, thank you. As I rightly said, diuretics is the main management. Other things like digoxin in special circumstances and other drugs we can use in this child. So this child also had hyperkinetic pulmonary hypertension. Will you treat this pulmonary hypertension?
This pulmonary hypertension is because of the large VSD. Because of the large VSD, there is a equalization of pressure on the left and right side. So there is no need to treat the hypertension here. The
Correct.
hypertension is not the predominant thing. If the the patient develops fixed hypertension, such as there is a RA-RV dilatation and there is a right to left shunt, then only we should start sildenafil. Sildenafil in this case will deteriorate the shunt because it will decrease the PVRI and there it will increase the shunt across the VSD. So sildenafil is strictly no in this case.
Why I ask, because few practitioners are using treatment for this pulmonary hypertension. So we should use sildenafil in only special situations.
Sir, I would like to ask all the panelists, like, since I have started practicing in Latur, what I have observed, any heart disease, everyone starts with the digoxin. So what is their experience in this scenario? Whether they are facing the same problem in Hyderabad, Mumbai and Nanded, as well as in Aurangabad? Because this is a problem I am facing in Latur.
Yes.
Even if I say
Most
no
of the
digoxin, I will see next time on follow-up, pediatrician has started on digoxin. And same thing sir has already explained that sildenafil should not be used in hyperkinetic PH. So what is your experience about digoxin?
Digoxin.
Side effect range. So even giving a digoxin is like a double-edged sword in case of over circulation failure, because they can have arrhythmias. If there is some electrolyte disturbance because of the diuretics, they can land up in cardiac arrest as well. So digoxin is very limited in very limited circumstances, such as if you have associated left pump failure or there is too much tachycardia in the child.
Yes.
This is over circulation, LV at volume overload. This is something working at the maximum of Frank Starling, according to Frank Starling law. So already this is the fastest running घोड़ा, उसको क्यों ही करना है और क्यों भगाना है डोबीटामिन, I mean digoxin देके. So it is not indicated at all. Very few incidences that time. Maybe something like LV dysfunction, all this factor, we may have to give digoxin. No routine use of digoxin, particularly in post-tricuspid shunt.
Yes, I totally agree with both of them. So digoxin should be reserved for specific cases. If there is a significant tachycardia, and here you have treated with anti-failure treatment, but still tachycardia persists. So that is one scenario. Another scenario, when there is a LV dysfunction, you can consider it, but definitely not a role when LV function is good and heart rate is controlled with anti-failure medications.
Thank you, Prashant. Now, Dr. Deepak, it's for you.
Can I just say a few words
about? We are following up the same case. Now, compliant to the treatment of all this congestive cardiac failure management, this child has become 3 months now. The weight is 4 kg. There is a clinical improvement. So, review diagnosis was large VSD, dilated LLV, hyperkinetic pulmonary hypertension, and there is no congestive cardiac failure. So, how long will you continue, Deepak?
First of all, thank Team MARPCON for the wonderful feast and Har Har MARPCON 23 Latur. Okay, this is something very typical case scenario what we get in our practice. This is rightly diagnosed at right time. I would say it is at right time. It present by 1.5 months, diagnosed, properly started treatment. Unfortunately, patient responded in the sense his CSF has gone, he's gaining weight and everything looks okay. On top of good thing is compliance to the treatment is good. Now, how long has it good to wait for this patient? That's the main question. Believe me, in these days, we are getting many patients with severe means irreversible pulmonary hypertension, that's Eisenmenger syndrome. This is only due to the delay in the treatment. How long to delay is the question. See, The Indian scenario, Indian guideline says up to maximum of another couple of months or maybe maximum 6 months we should wait. If the compliance is good, baby is gaining weight, everything is fair. Is getting recurrent respiratory infection in between, all this needs to be addressed. On top of, we need to address the compliance also. And we need to address his nutrition, immunization. These all things are very important. Maximum we can wait, even though he is far controlled with the anti-filler, we can maximum wait till 6 months, not more than this. Otherwise, we land with very bad scenario. We have diagnosed, we have done everything, and routinely somebody is saying, let them gain the weight, and the patient is losing his whatever the treatment modality from our side.
Thank you. Thank you. Maximum we can wait for 2 to 3 months, and then we should consider for corrective surgery for this child or a device closure for this child. So, Dr. Mahendra, this question for you. Now, this child is following up with you with the compliant to the treatment, anti-filler medicines he is taking regularly. Come back at 3 months of age. Now, weight is 3.2 kg. There is no much gain in the weight. So, how will you proceed with this child?
So now again, this, as we already discussed, first scenario we can see that the patient has a clinical improvement, and this in scenario we don't have a clinical improvement much after putting the patient on anti-failure. So, and the other diagnosis, one thing I want to highlight that we have a large VSD. Whenever there is a large VSD, we have to close it by surgical intervention. Okay, we don't have any kind of, so the practice, what was initially that every VSD get closed, that has to be embedded. Now VSD, if it is a large VSD, we have to go for treatment and surgical intervention, get it closed. Now the ideal situation, what have the IEP guidelines say and the world guidelines say, that 6 months is the ideal age to get operated VSD. Per se, it all depends upon the institutional practice also, and the institutional variation is there. In such case, when we don't have a clinical improvement, we have to take a quick decision, and because we need a good successful outcome for the patient, and we also have to improvement his life condition. So for this situation, definitely we have to involve the pediatric cardiac surgeon. We have to discuss among the parents also that this has to intervene early, though we have a high chance of risk, but for the clinical improvement and for the betterment, we have to get it treated surgically as soon as possible, because we don't have a clinical improvement after putting the patient on anti-failure also.
Now, for Sarang. Sarang, this child is compliant to the treatment, come back for follow-up at 3 months of age, gains weight, there is clinical improvement, a small to moderate size VSD. So what complication will you expect? Because we had case, had VSD and had complications. So what complication will you expect at this age?
The small to moderate VSDs, if they don't have, these are the complications which I already mentioned in the slide. One is we have to look whether there is an RVOT obstruction, but normally it doesn't happen so early. A VSD which has been followed up for a period of time only will manifest an RVOT obstruction because of the jet hitting the RVOT tract. Another most common scenario we see is the VSD apparently is large but looks to be small because it's trying to be restricted. So the VSD restriction can be because of the tricuspid wall, the septal leaflet, or it could be because of the aortic cusps trying to close off the VSD. When in this scenario where the aortic wall is trying to close off the VSD and there is a chance of aortic regurg, again, even though the VSD is small or if the gradients are on the higher side, we should not wait. The surgery is kind of an urgent surgery, because if we delay the surgery, then a simple VSD closure might turn out to be an VSD closure plus aortic wall repair, or sometimes in worst scenario a replacement as well might be needed.
As our panelists are saying, large VSDs we should operate early, and if this moderate size VSD causing problems, we should operate it without any complications.
And regarding digoxin and captopril,
yes,
normally I get patients referred from the cardiologist as well, and I go through the medications. I am very happy if they are just on anti-failure medications like furosemide and aldactone. Personally, I don't like children started on digoxin or captopril, enalapril. As my panelists have already mentioned, it is a surgical problem. Even a rate, and digoxin I don't think is a good rate control drug as well. it might help the Frank-Starling curve, but if the problem is a surgical one, medicines normally don't help. And I have seen a few patients who have been on digoxin, all enalapril, post bypass, when you try to come off, they tend to show a lot of arrhythmias, and we have difficulty maintaining them post-op as well. So I'm happy if my cardiologist or my physician has not started these medications.
Okay. We'll come to next case. Dr. Nitin. This case, 6 months old female child, complaint of not gaining weight, birth weight of 3.2 kg, current weight is 5 kg, and has continuous murmur. So I refer to you. So what is your course? How will you proceed in this child?
Okay, so I assume here that saturation is normal,
Yes.
and I consider this is a cyanotic case. So 6-month female, so there are a couple of clues here. So first clue is complaint of not gaining weight. So definitely there is some degree of heart failure. It may not be like frank heart failure, but there is a heart failure. So first thing that is, so I will go by the classification of a cyanotic heart disease. So I consider this is a cyanotic. So
Nutritional
first
part
thing,
and other part we have taken care of.
yes. So this is a post-tricuspid shunt, and most common post-tricuspid shunt with continuous murmur is a PDA. There are other shunts as well which can have a continuous murmur. So whenever there is a communication between aorta and pulmonary, it will have a continuous murmur. So first, most common is a PDA, and second one, if it is a small size AP window, might have similar finding. Another important thing, female child, incidence of having PDA in female is twice that of males. So I think this is a case of a PDA, second differential will be AP window, and third will be aortopulmonary collateral.
So we did echo in this child that is showing moderate PDA, mildly dilated LALB with hyperkinetic pulmonary hypertension and congestive cardiac failure. So how will you proceed now?
So simple funda about PDA, if there is a murmur in PDA, you need to close it. But the problem, the decision you have to take when to intervene. So all PDAs nowadays we are closing with the device. So previously it was a conventional thing that PDA or any cardiac procedure we used to refer for surgery. But in last 20 to 30 years there are lots of advances, and PDA nowadays is taken care by cardiologists than cardiac surgeon. So PDA device closure is recommended in this scenario because moderate size of a PDA is moderate. There is a dilatation of left heart and there is a heart failure. So, and child is already 6 months. I will just wait for another couple of kgs of weight gain. If child is more than 6 kg, I prefer to do the PDA device closure rather than waiting.
So short course of congestive cardiac failure drug management, and after that early closure, mainly device closure is possible in this child. So we'll proceed to another case. So what we have, because we are short of time, we are waiting for Jokes's lecture, so we are concluding early. Now this is half part we are finishing, this part A part. So we are now post tricuspid shunts. So what is our conclusion till now? Cyanotic post tricuspid shunts like VSDs, PDAs, etc. present around 4 to 6 weeks of life when pulmonary vascular resistance drops. Antifailure medications to be started depending on the clinical condition. Consider early surgical options if inadequate response to antifailure management. Large defect require early closures. All types of PDA can be closed with transcatheter interventions. PDA with murmur needs closure irrespective of the size of symptoms. Complicated lesions needs intervention irrespective of the size. Nitin, you want to add something in this?
Yeah, so rule of thumb in cardiology, whenever patient is symptomatic, you need to intervene. So, and whenever there is a complication, you need to intervene early. So I would like to just summarize approach to a cyanotic heart disease.
See, one thing, Prashant, I have not mentioned ASD in this. So what is your opinion about ASDs?
90% of the ASDs doesn't need a treatment till the age of 3 years.
Very important thing.
Okay.
ASD doesn't require individually treatment.
Only 5 to 10% of the cases which are associated with other lesions, like if it is a primum ASD with AV wall regurgitations, or if there is a left SVC with severe pulmonary hypertension, or ASD associated with TAPVCs or PAPVCs, that might need a early treatment, and usually the treatment will be around 6 to 12 months. Ideal age to close second term type of ASDs is usually 3 to 4 years. If it is a sinus venosus ASD, it is around after the school age, like 5 years.
Yes. Nitin, want to add something? Nitin, it's for you.
Yeah. So approach to a cyanotic heart disease, why we need to divide it? Because presentation is quite different in both the scenarios. First one is obstructive lesion, second one is shunt lesion. Obstructive lesion, there is obstruction to the flow, so cardiac output will suffer. So these patients will have symptoms related to cardiac output. The second group is a shunt group, so there will be pulmonary overcirculation. So this group will have heart failure symptoms rather than decreased cardiac output symptoms. Obstructive is further divided into right-sided and left-sided. So right-sided lesion can be pulmonary stenosis, tricuspid, and left-sided may be aortic stenosis and mitral. So most of the scenarios what we feel is left-sided lesions, they present early and the presentation is always serious as compared to the right one. Similarly on shunt side, if it is a pre-tricuspid shunts, they present later and needs intervention in late stage of life. While in contrary, post-tricuspid shunts need early intervention. We have discussed 2 scenarios already, so I won't go into the detail of this.
Thank you. Thank you, Dr. Nitin. Now we'll move to cyanotic heart disease cases. I have prepared few case scenarios. This 3-day-old neonate, otherwise well newborn, as a part of discharge workup, pulse oximetry was performed. We are doing pulse oximetries for the babies regularly. Pulse oximetry was positive. Baseline SATs were 86%, while oxygen saturation are 90% on O2. There is no obvious murmur in this child. Dr. Deepak, what is your opinion about this?
See, this is otherwise well newborn.
Yes.
I would congratulate this gynecologist who have done the routine pulse oximetry, because they have picked very critical lesion here, and probably they will be saving this kid. And I would suggest to cultivate all these pulse oximetry practices in all wherever postnatal rounds you used to go. A staff and a sensitive oximeter will do the most of the critical cardiac cases work in picking them up. This is baseline saturation 86, not improving with oxygen, hardly it is improving 90%, no obvious murmur. This is cardiac panel, naturally this is going to be a critical lesion, something heart disease. We need to differentiate why this is not respiratory. Naturally, the protocol we used to give oxygen, what we called hyperoxia test, hyperoxia cost, and after doing after hypoxia doing rather than PO2, we can directly go for saturations also. It's more easy to do. It will not improve more than 95 or it will not be 100. Very occasional cases when there is a lot of pulmonary overflow, that cases even false positive test may be seen in hyperoxia test. So this is some critical cyanotic heart disease patient. Probably TGA, no murmur.
See, it is very important for pediatricians. Whenever we are discharging the patients from our gynec side or first time visiting the patients for BCG vaccination or anything, we should do pulse oximetry. This is take home message, because once if you give BCG also or any vaccination, and if something goes wrong, if baby is having such kind of problems, we are in trouble. So it is very important to have pulse ox in our OPDs. Take some time, take 5 minutes or 10 minutes, whatever you want to. Sometimes, as some few panelists have said, few pulse oximeter are there, those can detect earlier. So this kind of patients will cause trouble in our OPDs, because this child can become bad at any time, become sick at any time. So everybody has to have pulse oximeter OPD before sending patient home.
One point to add is, there is a recent AIM study where they did a pulse oximetry as a screening tool for all the newborns, and still they found that 20% of the lesions can be missed even if your pulse oximeter shows the normal saturation.
That's very important thing.
Because if there is a large PDA, it will it will overshadow the symptoms of the critical heart diseases, and they may present after 1 week of life. So the advice to the pediatrician is, even if the saturations are okay after 3 days, you call them for follow-up after 1 or 2 weeks just to reassess the kid.
Very important. And refer early for echo. We can have more echos. So we did echo in this child, that is showing detransposition of great arteries. So what is your counseling, Sarang? Do you operate in this child, or do you have some suggestions about this?
Normally with unrestrictive ASD, they need to be operated within 1 month of age, because over a period of time, if they have left unoperated, that is, if the arterial switch is not done, the LV will regress over a period of time. And then from a corrective procedure, we might have to do a palliative procedure, which is called as the Sennings or the mustard. So early identification of such patients by echo. Some patients have an unrestrictive PA4 and ASD as well. They need to have a balloon atrial septostomy prior to the procedure as well, if they are having a restrictive ASD. So early diagnosis, early referral, and early surgery will be the advice for such patients. And the parents, I would tell them that it is a corrective surgery. If done at the right time, the child will have a normal or average lifespan.
So rightly said, Sarang. We should refer surgical cases, though those are complicated, because our cardiac experts are there. In our residency days, we used to see post-cardiac CVTS wards. Those were havoc. Whenever there is a case, whatever it may be, VSD operated PDAs, difficult to survive. But now complicated cases are there. Those are managed by all these cardiac teams. Okay. Few cases.
We are short of time, sir.
Yes. Okay. So Dr. Sarang, this 3 days old neonate, otherwise well newborn, during morning rounds, mother reported that child is not feeding well and baby's color appears pale. These are common scenarios those who are facing, because baby is normal few hours back and now baby is getting in serious condition. So during morning rounds, mother reported that child is not feeding well, baby's color appears pale, dusky grayish, poor peripheral circulation, radial pulses are not failed, femoral pulses are not failed, pulse oximetry is 70, and while on oxygen, saturated 80%. So no obvious murmur. So what is your differential for that?
Actually, I wanted to know whether there is a upper limb and lower limb saturation difference in this case. Looking at the baby, the 3 days old, which was normal, and suddenly presenting with warning signs, it's all indicates a duct dependent lesion, and most probably as he is presenting at the 3rd day with symptoms of failure, usually it is obstructive lesion, which is a left sided, maybe critical aortic stenosis, critical coarctations, or hypoplastic left heart syndrome, or large interrupted aortic arch. So
we did echo in this child showing hypoplastic left heart syndrome. So basically we should refer early. Whenever there is little doubt, we should refer directly to our cardiologist for echo and have some diagnosis. A lot of cases, still we'll summarize the case. Early presenting two common cyanotic heart diseases are TGA and duct dependent pulmonary circulation. Late presentation presenting cyanotic heart disease without heart failure symptom is most commonly TOF, that is or TOF physiology. Surgical correction is only best option for cyanotic heart diseases. Overall outcome is good if intervened on time. Nitin, you want to add something in this?
Hello. Yeah. So regarding cyanotic heart disease, it is very easy to summarize, because it has only 2 groups. Either you have to decide whether this patient is in group A or group B. So simple funda is that whenever there is a desaturation, always look for heart failure symptoms. If heart failure symptoms are not there, it means this is a reduced pulmonary blood flow situation. Another group is where there is a mixing lesion or increased blood flow situation, where there will be desaturation or cyanosis. In addition, there will be heart failure symptoms. So you need to categorize here, because heart failure symptoms need treatment. Cyanosis has a specific, if it is significant pulmonary stenosis, we might start some medical management and surgery. But all cyanotic heart diseases will definitely need surgery. Timing of surgery depends on whatever underlying anatomy.
There is time issue, so we are just forwarding few cases. Okay. Dr. Deepak, it's case for you. We have 26 years old, 26-year-old female, referred by our gynecologist with 20 weeks of gestation, primary, self-referral for advice, antenatal UAG showing persistent left-sided heart, gynecologist advised termination of pregnancy. What are your views?
Sir, this is the most common scenario nowadays because we have a fetal medicine as a super specialty available. Left SVC is a persistent structure. In embryogenesis, we have that connection which connects your coronary sinus and it ultimately drains to your RA. So it is a obligatory vessel that is going to persist in a whole of life. And this is not basically a disease. This is just an anomalical variation of the body that we have. So termination, definitely there is no need of that point over here. Left SVC sometimes is considered as a soft marker for trisomies. So if the gynecologist is willing, we can just evaluate the fetus for that. Otherwise, left SVC is a benign structure.
And ecogenic foci?
I would ask who has done the antenatal USG first. Because
So
most of the times, the fourth vessel which is seen is labeled as persistent left SVC. But many a times, it can be a left-sided vertical vein, which is seen in the supracardiac TAPVC. So if it is done by a fetal medicine specialist or the pediatric cardiologist, persistent left SVC will not cause problems. But we have to always roll out the supracardiac TAPVC in this case. And single echogenic focus is not a marker for any congenital heart disease or any genetic isolated echogenic focus. If it is associated with any other systemic abnormalities, maybe it is indicative of some genetic malformations.
Okay. Thank you, Prashant.
Sir, small comment. So whenever there is a cardiac finding in fetal analysis, I think everyone should refer to pediatric cardiologist, because what happens, diagnosing a disease is not difficult. What we need to do afterwards, or whether this condition is benign or needs treatment, that we have to do. Because most of the time radiologists and fetal medicine guys, they label something, goes to gynecologist, they always say heart disease better to terminate. But there are most of the heart diseases, they are either benign or self-curing during further gestational age. Thank you.
There is one case last. Because we are commonly facing this kind of problems. 5-day-old neonate preterm, born at 28 weeks of gestation, 1.8 kg, not able to wean from CPAP. Now baby is with us, at present with us, not tolerating feeds. Baby has baseline tachycardia and tachypnea. Other safety component and other conditions we have ruled out. Tachypnea reduces with minimal CPAP support. How will you proceed? Dr. Deepak, sir.
The NSU has done a good job. Must have given surfactant, sepsis control. What is left here for tachypnea and cardiac panel is something like a PDA. Whenever there is PDA, hemodynamically significant PDA, its tachypnea will worsen, and there will be some increased requirement of the PWP or CPAP requirement will increase. CPAP PDA per se causes hypotension and pulmonary overcirculation. Pulmonary overcirculation will cause symptoms like tachycardia, tachypnea, and this is one not tolerating feed. This means there is systemic hypotension that can happen here in intestine, brain, lungs, and so where. So we need to control this. This looks typically scenario in NICU of a hemodynamically significant PDA.
Yes, we did echo that is showing large PDA. So how will you proceed now?
There are a lot of work, lot of studies, but no very confirmative conclusion on treatment part. But still, hemodynamically significant PDA with symptoms, with this one, echo criteria to label this as hemodynamic, like LAO ratio and all these criteria. Neonatologists have brought lot of criteria. This has to be treated. Regarding drug, what drug? Again, the question remain unanswered. This is most studied is endomethacin followed by ibuprofen and paracetamol. Ibuprofen is usually preferred because of his least side effect, less side effect than endomethacin. This paracetamol, more studies has to go, but this is safest one. This is something for non-significant PTA. It can be something like a placebo. It can work like a placebo. But definite significant hemodynamic PDA needs to be treated with ibugesic or endomethacin according to the patient condition. If not, then surgery. If not, then surgery.
Sir,
As this is the last case, before sir concludes, one small remark. Yeah. So there are two scenarios, PPHN and PDA in NICU most of us face. And before giving blanket therapy, I think if you have access to diagnosis, you should diagnose this before giving the treatment.
Thank you.
really,
Thank you for the patient listening.
really, it was a great knowledgeable session with such fantastic panelists and moderator with no limits of knowledge and enthusiasm of moderation. I request Dr. Nitin Yelikar sir to facilitate our moderator, Dr. Udgirkar sir.